I got 10 o'clock, so we're going to go ahead and get started. So we're talking about shock and resuscitation. So for the big part of this, I'm mostly just going to be covering shock because that's probably the most difficult portion of all this. Resuscitation is really just kind of boiling down to what you guys did last week with your AHA CPR. Everybody got their BLS last week, right? Basic life support cards. Okay. Get with me. We'll look at that. All right. So shock. So just in layman's terms, what is shock? What is it?
Just your body going into some traumatic issue that happened.
Okay. Well, what is your body doing? What is or not doing? Really?
It's not functioning how it should be. It's dying.
The big thing here is that your body is no longer perfusing. Your cells are no longer perfusing. They're no longer getting oxygen and energy that they need. So, did you guys in your first couple weeks, did you guys talk about like how cells actually create energy, ATP and all that? You guys remember that, or is that a paramedic that I'm thinking of? Okay, well, we'll kind of briefly talk about all that in a bit, but shock is where your body is no longer perfusing the cells. Okay, so it's an inadequate state of perfusion, like you see up here. So definitely know that definition because you're probably going to see it again. All right, so it's inadequate perfusion of the cells. They are no longer getting the oxygen that they need to start creating energy. So when we talk about shock, all right, so there's several different aspects of it. All right, the biggest is that the tissue, the cells are not perfusing. All right, but in addition to that, we're not removing waste products. Okay, so when your body goes without oxygen for so long, you move from an anaerobic to an aerobic state. Okay, so you're going from with oxygen to without oxygen, and I might have just mixed those two up a second ago, but your body's moving from a state of where your cells have oxygen to where they no longer have oxygen. All right, so they have to rely on a different method in order to create that energy. And unfortunately, one of the byproducts of that is lactic acid buildup. And that's what one of these wastes are when we talk about inadequate waste product removal. All right, so here it is. The shift from aerobic to anaerobic. And like I said, I might have just confused the two a second ago. But aerobic is with oxygen. Anaerobic is without oxygen. All right, we're not going to talk about the sodium-potassium pump because that's more paramedic level. But it's still important to kind of have a general idea of what that is. And we'll get to that. But when your cells go from that aerobic to anaerobic, one of those products, like I said, that's created, one of the waste products is lactic acid. You guys ever been working out real hard and then afterwards your body just feels juiced? Okay, you can feel the buildup of lactic acid. All right, that's because your body has moved to an anaerobic metabolism. All right, we're going to get past that. So oxygen is key to survival here. We have to get oxygen to our cells. And the only way to do that is through respiration. All right, so we got to give oxygen to our cells. And if we can't, it's not we, but if our patients can't breathe, we're going to have to breathe for them. We're going to have to ventilate them and oxygenate them. And again, where does that gas exchange occur? Right here at the alveoli. Okay, what gases are exchanged right there at the alveoli? Oxygen and what? CO2, which is carbon dioxide. All right, so we're going to talk about three different things here, and it gets complicated because they all interrelate. So when we talk about the etiologies of shock, we're talking about big picture, why does shock happen? It happens because there's a problem with one of three things. Either inadequate volume, okay, so either the whole blood or plasma is inadequate. There's a problem with the pump, and that pump being the heart, or there's a problem with the vessel tone, and we're talking about our blood vessels. All right, so those are the big picture 3 main reasons why shock occurs. All right, we're also going to talk about what is cardiac output, okay, and exactly what is our blood pressure. All right, so moving on. The first one, when we talk about volume loss, okay, we're still talking about the big picture, the 3 etiologies of shock. When we talk about inadequate volume, we're talking about decreased blood volume. Okay, so what's one reason somebody could have decreased blood volume? A hemorrhage, right? Okay, so there is some type of, I think somebody said laceration, so there's some type of cut or injury to the body, and we are losing blood. What's another reason we might lose blood in women? Yes, some women have excessively heavy menstrual cycles, okay, and they can have these similar problems. They're often placed on an iron supplement, okay? Because why are they placed on an iron supplement? Say again? Iron helps with the production of red blood cells. All right, so when we're talking about inadequate volume, we're also talking about, like we talked over here, when we talked about what cardiac output is, okay, we're talking about stroke volume. When we talk about decreased preload, okay, and stroke volume, if we don't have enough blood actually getting to our heart, this is what we're talking about. There's not enough blood actually arriving to our heart. There's not going to be able to pump that through the rest of our body. Okay, decreased cardiac output causes a drop in systolic blood pressure. Okay, that's our top number, right? Okay, that's the big number that we really want to be looking at, because if our systolic blood pressure is too low, we're going to be hypovolemic. Hypovolemic. Or hypotensive, rather, than possibly hypovolemic. So here's some other reasons why we might have decreased volume, okay? So we're talking about whole blood. We said bleeding, okay, whether it's through an injury or maybe through excessive menstrual cycle. Vomiting and diarrhea, okay? So we just kind of went through the another recap of the flu season, right? So that's where we might have excessive diarrhea or excessive vomiting, okay? And kind of incorporate that with excessive urination. What kind of age group do you think of that might have excessive vomiting, diarrhea, or urination? Our infants, our very young pediatrics. Okay, so you might get a question on the exam that's talking about you have a 9-month-old infant, and the mother tells you that he has had 13 episodes of urination. So she went through 13 diapers in a span of 8 hours, and he's been vomiting, and he's also had excessive diarrhea. So a question might be like, what type of shock is he in? So what type of shock would he be in? This is kind of jumping ahead. Hypovolemic shock. So hypo meaning low, volemic volume, so low volume shock. Why is he in low volume shock? He hasn't bled. Because he's losing all of his fluids, okay? He's losing the plasma volume, okay? So plasma is a part of our whole blood. So he's losing all that plasma in the blood. So he is hypovolemic with that excessive urination or excessive vomiting or diarrhea. All right? And then we also have this option down here, increased capillary leakage. We see that with burns. So these are 4 or really 5 areas where we might have a patient that is going through hypovolemic shock. And the etiology is inadequate volume. how do we replace that? How do we replace that volume in a patient? So what?
We do not, well, we can't do none.
Yeah, so EMTs, we can't do IVs. So that's out of the option. What can we do? Not really much of anything, honestly. If they can drink water and hold it down, they probably wouldn't have called us. So we just need to get them to definitive medical care. All right. So if it's just an example of nausea, vomiting, diarrhea, okay, or excessive urination, then for me as a paramedic, an IV might be enough. But what if they have been bleeding out? Let's say they have a laceration to a major artery. What is the definitive care for them? IV fluid's not going to cut it. What do they need? They need blood. They need whole blood. They need whole blood. Not just packed red blood cells. They need whole blood because that's going to have the plasma as well. Okay, that's going to have the plasma. All right, so we talked about volume. Now we're going to talk about the pump being the heart. Okay, so it doesn't matter how much fluid we have in our body. If our heart is failing, it's not going to be functional, or our patient's going to go into shock. All right, so why does this occur? All right, so there's several different reasons that can occur. One could be congestive heart failure, okay, but there's also some other options where we have myocardial infarctions. What is that? What is a myocardial infarction? It's a heart attack, okay? What causes a heart? What is the primary cause of a heart attack? Okay, so our blood vessels in the heart have become clogged, or they're narrowed. With what? Fat. Okay? So that's called atherosclerosis. You're going to see that on your national registry. It's called atherosclerosis. All right? That's where you have the arteries that are clogged up. Atherosclerosis. Not to be confused with arteriosclerosis, which is the hardening of the arterial walls. All right? So you're going to see one or both of those in your national registry, guaranteed. All right, so inadequate pump function. So it could be caused by a MI or a heart attack. All right, CHF, like we're talking about, congestive heart failure, or a mechanical obstruction. And it gives two options here. And we're going to talk about these to death, okay? We're going to talk about these to death, and then you're going to get it even more when we talk about trauma, when you get to that section. But I'm going to beat it up here. That way, when you get to trauma, you're going to be like, oh yeah, I already know all this stuff. All right, so the first one, a pericardial tamponade. Pericardial tamponade. What is that? Peri means around. Cardial is the heart. Okay, so the pericardial sac is the sac that sits around your heart. So that sac can fill up with fluids, most oftentimes blood. So let's say you had someone that was stabbed in the chest. Okay, they're stabbed in the anterior chest on the left side at approximately the 4th intercostal space. What's right there? Your heart. Okay? So let's say they're stabbed. Let's say it wasn't a very long blade, but it was long enough to actually stab the heart itself. Maybe not too deep, maybe not too severe, but it was enough to stab the heart itself. So that blood that's leaking out from the heart is going to fill up that sac, that pericardial sac. And because the heart continues to pump, what's going to happen with that sac of blood? it's going to continue to fill up. Right? So that sac is just going to continue to fill up with blood. And if I have my heart inside of that sac that is just full of blood, it's going to become more and more and more difficult for the heart to pump. So every time my heart takes a beat, lub-dub, it's pushing blood into that pericardial sac, filling it up, making it more and more difficult to beat. And eventually, that blood is going to back up. It's going to back up. What's going to back up into? What's up here in our neck? Wait, what? We do have lymph nodes there. We do have arteries. But that's not what I want to hear. I want to hear, it's an acronym. Starts with J. Jugular vein distension. Okay, so JVD is a common sign of pericardial tamponade. So I have JVD. Breath sounds. What do you think they're going to be like? They're probably going to be normal. They're probably going to be normal in a pericardial tamponade. Okay? So in a pericardial tamponade, my breath sounds are probably going to be normal. I'm going to have JVD, and I'm probably going to have muffled heart tones. So whoever was filling this out, this is what we're talking about here. I got JVD, muffled heart tones. Okay? This is what we're going to see on a pericardial tamponade. So this is a problem with the pump, right? This is a mechanical obstruction. All right, so that's a pericardial tamponade. Now we're going to talk about a tension pneumothorax. I hate this picture, but it does describe what's going on. So, tension pneumothorax, let's break that down. Tension meaning pressure, pneumo meaning air, thorax being the chest. So I have a buildup of air causing pressure within my chest cavity. So let's say I'm shot, okay? Let's say I'm shot and it punctures my chest wall and punctures my lung. So every time I take a breath, okay, air comes in, okay, good, and I exhale, air goes out. But if my lung has a hole in it, where is that air going to go? It's going to go out that hole, okay? It's going to go out that hole. So until I place a bandage over the chest, I'm going to have what's called a sucking chest wound, and you're literally going to hear a gurgling sound from it. Okay, you're going to get more of this in your trauma lecture, but again, I'm just beating this up so that when you get to it, it's already old hat. You already know all this stuff. Okay, but I'm going to hear a gurgling sound that's a sucking chest wound, but when I place an occlusive dressing, or we're talking about something that air cannot pass through, like plastic, place that dressing over it, great. Okay, air's not getting in or out of that hole, but that means that I still have a hole in my lung. So air is still going to escape there. So every time I take a breath, okay, take a breath, all right, good, I got oxygen to my good lung, it's going to the alveoli, and the gas exchange occurs, and I breathe out carbon dioxide. That's not happening on the injured lung. It's not happening on the injured lung, and when I exhale, air is just going out of that hole. Eventually, all the air is going to build up in my chest, and it's going to continue to push everything to one side. It's going to push everything to the opposite side that you're injured on. So if my right lung is damaged, everything's going to be compressed to the left. What are some signs I might see in a tension pneumothorax? What might I see up here? In my neck? JVD. Okay, so I'm going to see JVD in a tension pneumothorax and a cardiac tamponade. But here's a big difference. When I listen to breath sounds for somebody that has a suspected tension pneumothorax, what is it going to sound like? It's going to be diminished or absent. Exactly. It's going to be very diminished or absent on the injured side. So whereas a cardiac tamponade, I'm most likely going to have good, clear breath sounds, but in a tension pneumothorax, that's not going to be the case. Okay, so not only do I have jugular vein distension, but I may have tracheal deviation. You guys remember that in your patient assessments? Okay, tracheal deviation is another thing that we may see with someone that's suffering from a tension pneumothorax. So again, if I'm injured on the right side and everything is being pushed to the left, which way is the trachea going to start to migrate? To the left. It's going to go in the opposite direction of the injured lung. So what does that mean for my heart and my good lung? It's going to be compressed with what? Air. It's going to be compressed with air. So every breath I take is just crushing my heart and my good lung more and more and more. How do I treat that? As an EMT, how can I treat that? That would be great if we were paramedics. But as an EMT, how do I treat that?
Hand them over to the paramedic.
Okay, that's another option, have ALS en route. So remember that dressing that we placed initially? We're going to remove it temporarily. It's called burping the wound. Okay, it's called burping the wound. Again, you're going to get all this in trauma, okay, but this is just good stuff to know because this is shock. How do we treat this? Okay, we're talking about why it occurs, but we also need to know how do we fix this? Is there anything that we can do as EMTs for a pericardial tamponade? No. There's that fluid in the sac, and we just got to get them out. Okay, nothing we can do. Tension pneumothorax, definitively, there's nothing we can do. All that we can really do is just continue to monitor our patient and occasionally burp the wound if necessary. And even here in the picture, it says treated with needle decompression, okay, which is what you were talking about a second ago, all right, which is one option, or more definitive than that is a chest tube. Someone with a tension pneumothorax needs a chest tube for definitive treatment. But we're not doing any of that. All right, so now we're going to talk about the third etiology of shock. So we talked about inadequate volume, inadequate pump. Now we're going to talk about inadequate vessel tone. So what is one reason that someone might go from normal sized vasculature to spontaneous or rapid dilation across your entire body? What's one reason that we as EMTs might come across, and it's something we can fix? Let's say someone's allergic to bees and they get stung by a bee. Anaphylaxis. What happens to someone's blood vessels when they are going through anaphylaxis? They dilate. They dilate. So what happens to their blood pressure? It drops. So they get dizzy. They have all those problems and complications. So that's one reason that they may have massive vasodilation. And there's other reasons that we're going to talk about when we get into more of the categories of shock. All right, inadequate vessel tone. So massive vasodilation. We're talking about, like we just said, sympathetic nervous system function or chemicals released within the body. So maybe they are having a reaction, an allergic reaction, maybe to medication, food, insects, flora, fauna, that kind of stuff. Treatment includes vasoconstriction and volume restoration. How do we treat vasoconstriction as EMT, or vasodilation as EMTs? What can we give? Epinephrine, how much? No. 0.3 milligrams. 0.3 milligrams. If they're a pediatric patient, 0.15 milligrams. So we know anaphylaxis, we give epinephrine. Because one of the major problems that they're having is that massive vasodilation. Another problem that they're having is that bronchial constriction. So the bronchial constriction. So not only is it more difficult for them to breathe, to get that gas exchange going on top of that, their blood pressure is bottoming out. And so the heart is going to have to pump harder. They're going to have to pump faster. They're going to have to breathe more often, probably more deeply, just to get the same result that they had a moment ago. All right, treatment of shock depends on the underlying cause, and we're going to talk about a lot of those underlying causes, so consider requesting ALS. Here's the real deal. If you are on a BLS truck, it's just you and another EMT, and you have a suspected shock patient, who should you be calling to meet you en route? ALS. All right, here's a bunch of different categories, and we're going to talk about these in depth. All right, so we talked about the etiologies of shock. One of those was what? What was the first one we talked about? Inadequate volume. So now we're going to talk about the categories. We're going to talk about hypovolemic shock. Hypo meaning low, volemic, volume. Hypovolemic shock. Low blood volume. But not just low blood volume. What else could be missing? Specifically, plasma. The plasma that is a part of the blood. Hemorrhagic shock, or hemorrhage, is the most common cause of hypovolemic shock, which is a form of hemorrhagic shock. Okay? So we're going to break down hypovolemic shock into two different subcategories, hemorrhagic and non-hemorrhagic. And we're going to talk about those in a second. We'd also have burns, where we have that capillary leakage. All right, so like I said, we have these two categories, hemorrhagic and non-hemorrhagic. Hemorrhagic is loss of whole blood. Definitively, how do we fix this? They need whole blood. Can we as EMTs do that? No. All right, so we got to get them to wherever they need to go as quickly as possible. Okay, probably a trauma center. Non-hemorrhagic, okay, loss of plasma. What are some reasons that they may lose plasma? Diarrhea, vomiting, excessive urination. Okay, excessive urination. What is the what's another cause of non-hemorrhagic loss of plasma? We just talked about it. When we lose from our capillaries due to burns. Okay? There's also just good old-fashioned dehydration. Somebody just not drinking or eating enough. They can go on long enough that they eventually go into non-hemorrhagic hypovolemic shock. Another category is distributive. So we're talking about caused by vasodilation. All right. What did we say was one reason for vasodilation? Anaphylaxis. Okay. That's a big one. Cardiogenic shock, okay, or caused by an inability of the heart to pump blood effectively. So we have something going on with the heart. What were some of those reasons that the heart could not effectively pump blood? The fluid around the heart, what's that called? Pericardial tamponade. That's one. What's another one? It's not, when I put a dressing over it, a lot of pressure builds up, and it's called a blank, blank, blank. A tension pneumothorax. A tension pneumothorax. That's two. What's another one? What does MI stand for? Okay, CHF, that's one. And myocardial infarction, which is a heart attack. So those are 4 reasons why we might go into cardiogenic shock, because of an inability of the heart to pump blood effectively. Okay, so MIs, or a heart attack, myocardial infarction, congestive heart failure, tension pneumothorax, and a pericardial tamponade. Those last 2 are mechanical obstructions that can affect the heart. That's why this is so confusing, because you have not only the 3 overarching etiologies, but then you have subcategories, and then within those subcategories you have even more definitive categories of shock. Like we talked about in hemorrhagic, we have, or excuse me, in hypovolemic, we have hemorrhagic and non-hemorrhagic. So it gets to be very confusing, but it all relates back to the same thing. They're not perfusing. Okay, so we talked about heart attack as a cause of cardiogenic shock. Okay, heart attack, also known as a what? MI? What's it stand for? Myocardial infarction. Okay, we have to know this with these definitions. We need to know this terminology, because if we don't know it, we're going to get to the test. We're going to I don't know what any of this crap means. Okay, so we need to know what these terms mean. All right, obstructive shock. This is another category. So obstructive shock. So we have a condition that results in a obstruction of forward blood flow. Here's some different causes. Pulmonary embolism, or a PE, tension pneumothorax, or pericardial tamponade. We just saw those a second ago. Okay, but they are also forms of obstructive shock. I know, so it all kind of gets very, very confusing here. So pulmonary embolism, what is that? Pulmonary. What is the pulmonary system? When we talk about pulmonary, that is our lungs. So pulmonary embolism is, I don't know if you can see on the photo right there, but a blood clot is stuck in our lungs. So blood clot is stuck in our lung. We have this obstruction. So it's stuck in our lungs. So blood cannot flow all the way down to the alveoli. The gas exchange cannot occur. And because the gas exchange doesn't occur, we don't get the oxygen that we need. Okay, another one is tension pneumothorax. We talked about this. There's a hole in the lung. Okay, and the buildup of air compresses the heart and the good lung. You can also see in this photo the trachea is starting to move in the opposite direction of the injured lung. Whereas in these other 2 photos, they're just straight up and down. This one is slightly curved. And then lastly, a pericardial tamponade. What's going on with this? Yep, fluid in the heart sac. Okay, we call that heart sac the pericardial sac. All right, so this is obstructive shock. Okay. So here is another category, metabolic or respiratory shock. All right, so this is something a little more difficult to wrap your head around, because earlier we talked about aerobic and anaerobic metabolism, right? Going from with oxygen to without oxygen. So there's a couple different reasons why this can occur, okay? Dysfunction in the ability of oxygen to diffuse into the blood, be carried by hemoglobin, offload of the cell, or to be used effectively by cell for metabolism. Let's talk about this one right here. Be carried by hemoglobin. If someone is involved in a house fire, what gas may they start inhaling? Carbon what?
Carbon dioxide.
No, monoxide. Carbon monoxide. Okay, so carbon monoxide, so carbon dioxide, CO2, okay, because dio, or carbon monoxide, mono, so we're talking CO2 or CO, carbon monoxide. If someone is in a house fire and they have inadvertently inhaled a lot of carbon monoxide has a much greater affinity to hemoglobin than oxygen does. So the carbon monoxide is going to bond with the hemoglobin in your blood. So if the carbon monoxide is bonded with the hemoglobin in your blood, what does that mean? Where does the oxygen go? It doesn't bond to your hemoglobin. So if it can't bond to the hemoglobin, what happens to it? It's just floating around, okay, not doing its job. So somebody that was in a house fire, if I put a pulse ox on them, what do you think their pulse ox is going to look like? What's that SpO2 reading going to be like? Super high. It's going to be super high. But that's very misleading. Why is it happening like that? Why is that so misleading? Well, a pulse ox doesn't actually read the amount of oxygen in your blood. It instead reads the amount of hemoglobin in your blood. So if your hemoglobin has all that carbon monoxide bound to it, your pulse ox might say 99%, 100%, 98%, all excellent readings, but in reality, they don't have much or any oxygen in their blood. A side effect of carbon monoxide poisoning is cherry red lips, or just a red tint to their skin. So what do you do for those guys? How do you treat that? High flow oxygen. Okay, using what? What are we going to give them? What are our options? Non-rebreather? BVM. Okay, non-rebreather. What's the minimum that we set that to for liters per minute? Yeah, between 10 and 15 when we're talking about high flow oxygen, right? Same with the BVM, 10, 15? Okay, so this is somebody that is in metabolic shock. So they have, and we're just talking about just that specific instance of somebody in a fire. There are other reasons why this can happen. So like we were saying, they may have been exposed to a lot of carbon monoxide. All right, another example is hemorrhagic hypovolemic shock. Okay, this is a very specific type of shock when we're talking about loss of whole blood. And earlier, I was talking about plasma, okay? Plasma being a part of the entirety of what we call blood, makes up for over 50% of it. All right, so we're talking about hemorrhagic. That means that they are bleeding out. They are bleeding out. And if they are bleeding out, we're losing the whole blood. So that means we're losing the plasma, we're losing the white blood cells and platelets. What do platelets do? They help with clotting. But if we're losing all that, we're losing our biggest factor that helps us clot. So we're losing the fluid, we're losing our ability to clot, and we're losing the red blood cells. What do red blood cells do? Carry oxygen. So our our hemorrhagic shock, okay, is incredibly difficult to stop and control because we're losing all of this. We're losing the fluid. We're losing the platelets. We're losing the red blood cells that have the hemoglobin and hematocrits. So it says administration of IV fluids can be helpful. Yeah, it's great. It's really helpful in both of these, okay, because that's going to help get our blood pressure up. But we can't do that as EMTs. And someone in hemorrhagic shock, what's the biggest thing that we have to worry about? Someone that was bleeding out, what's our number one concern? Stopping the blood. Okay, we got to stop the blood. We have to stop the bleeding. Here's the situation. We are called out to a factory. Doesn't matter what the factory is. We get there and we see an individual that is lying on the ground. He has let's say he has his back up against a wall, and you see a lot of blood pooled around his right leg. Okay, we see a lot of blood pooled around his right leg. It is bright red blood. What type of blood vessel did that come from? Artery. Okay? What is some characteristics of arterial bleeding? Bright red bleeding, that's one of them. Spurting. Okay? So let's say it's no longer spurting. What does that tell us about our patient? That they are very hypovolemic. That their blood pressure is very low and the spurting can't even occur anymore. So they're hypovolemic, and they're probably in what kind of shock? Hemorrhagic shock. They've lost a lot of blood. Okay? Lost a lot of blood. How do we treat those guys? We're going to put a tourniquet on them. We're going to give them oxygen. What else are we going to do? How else do we treat shock? We need to keep our patients warm. There you go. Because what's one of the biggest indicators of shock? Cool, clammy skin. Cool, clammy skin. It's one of our biggest indicators of shock. That cool, clammy skin. Yeah. Keep them warm. Put a blanket on them. What else can we do in the back of the truck? We can turn the heat on. That's going to suck, but it's going to help save their lives. Okay? So, stopping the bleeding. High flow oxygen. Rapid transport. And keep them warm. Okay? That's going to be our job while we are transporting these patients. If they are in non-hemorrhagic shock, okay, so they've lost a lot of fluid, but it's not because of bleeding out. It could be from vomiting, diarrhea, excessive urination, excessive sweating is another option. You guys have heard of like your heat injuries? Heat exhaustion, heat cramps, heat stroke, okay? What can you guys tell me about heat stroke? The body gets too hot. It's a medical emergency. They're super dehydrated, but they're already dehydrated for heat exhaustion as well, and that's the lowest. What are some of the signs we might see in someone in heat stroke? Okay, that's a big one. They are likely to stop sweating. Why are they likely to stop sweating? There's either no more fluid in their body, or their brain is literally so hot that it's no longer sending the signals to your body to sweat. So that is a medical emergency, and we need to give them fluids. But we can't give them IV fluids. If they are alert and oriented and they can hold something down, maybe fluids, but more often than not, we're going to withhold fluids from our patients. Okay, more often than not, we're going to withhold fluids from our patients. Especially in an instant like hemorrhagic shock because they probably have to go into surgery. All right, so we're going to talk about burn shock. So this is a form of non-hemorrhagic because they're not bleeding out, but they've lost a lot of plasma. And this plasma is leaking from damaged capillaries. So they're bleeding out from damaged capillaries. Anaphylactic shock, okay, we said that there was various reasons this can occur. Food, medications, flora, fauna, okay, animals or plants. This causes massive systemic vasodilation. All right, so anaphylactic shock, what etiology of shock is this under? Inadequate vessel tone. Inadequate vessel tone. Because why? What's happening? What's happening to our blood vessels? They're all dilating across our bodies. So what's that going to do to our blood pressure? It's going to decrease it rapidly. What's that going to do for getting blood to our tissue? It's going to make it much more difficult. And how do we treat that? Epinephrine. What's the dosage? 0.3 milligrams for adults or 0.15 for pediatrics. Here's another form of septic shock. Okay, this is another form of shock. It's called septic shock. This is a type of distributed shock when we talk about bacteria and toxins in the blood. So these patients, we often see this in nursing homes. We often see this in nursing homes where our patients are septic. Okay, they just have massive infections throughout their entire bodies. And then this kind of breaks it all down for what we might be expecting to see in a patient with sepsis. Excuse me. So their temperature is going to be high. It's going to be elevated because they likely have a fever due to infection, rapid heart rate, rapid respiratory rate. They may have an altered mental status, and their glucose level is probably less than 120. We may also see decreased blood pressure, decreased SpO2. Okay, these are all things that we may see in someone that is septic. All right, here is a very specific type of shock, and we need to pay close attention to this because you're probably going to have a test question specifically on this. So, someone that is, let's say they're in a car accident. Let's say they're in a car accident and they sever their spinal column. Okay? So they have an injury to the spinal cord. That can affect their ability to maintain vessel tone. So they get widespread vasodilation. They get widespread vasodilation. So in neurogenic shock, this is the only kind of shock where we see warm, flushed skin. So neurogenic shock, warm, flushed skin. Everything else we see pale, cool, clammy. All right, cardiogenic shock, we talked about this a little bit before, includes acute myocardial infarctions, which are heart attacks, congestive heart failure, abnormal cardiac rhythms, or possible overdose on certain drugs. Okay? Drug overdose. What can we as EMTs do? Is there much we can do for drug overdose? No, not except in very specific instances, like opioid overdose, and we can give them Narcan, which is also known as naloxone. Yeah. Yeah. Abnormal cardiac rhythms, okay, these can be causes for cardiogenic shock. And we're going to talk about some abnormal rhythms when we get to the resuscitation portion of this lecture. All right, so how does our body respond? So we talked about all these different types of shock. Now we're going to talk about the body's response to it. So the body's going to attempt to compensate. How does it attempt to compensate? By elevating heart rate, elevating respiratory rate, trying to increase blood pressure, which is going to help. It's going to help perfuse our cells because we need to get blood, oxygenated blood, to our cells. All right, so we talked about this. This is called sympathetic stimulation. Increase in heart rate, increase in force of ventricular contraction. This is going to increase our blood pressure. Vasoconstriction. It's going to try to vasoconstrict. Vasoconstriction increases our blood pressure. Stimulation of the release of epinephrine and norepinephrine from the adrenal glands. Epi, what do we say epi does? What does it do to our blood vessels? Constricts them. Okay, so all this is happening simultaneously. All right, epinephrine has alpha and beta effects, and norepinephrine has alpha effects. I doubt you're going to see any questions specifically on these, but you might. Okay, it's probably unlikely, but just know what epinephrine does. Causes vasoconstriction and increased cardiac output. Norepinephrine causes vasoconstriction. All right, here we're talking about alpha, beta receptors and all that. Again, this is more in line with what you're going to learn in paramedic school when you hopefully go. All right, the stages of shock. So we talked about the etiologies of shock. We talked about the categories of shock. Now we're going to talk about the stages of shock. There's really a third stage. Okay, there's really a third stage. So we have compensatory, decompensatory. What do you think that third stage is? Irreversible. Irreversible shock. There's just no coming back. They're on that downward spiral and they're done. Okay, this has a good diagram of how hemorrhagic shock affects the body. And when you get to your trauma lecture, you're going to learn about what's called the lethal triad. And this is kind of the beginning touches of that. Dipping our toes in the water when we're talking about it. All right, compensatory shock. The body's able to maintain near normal blood pressure and perfusion of vital organs. What are our vital organs? Brain, heart, lungs, kidneys. Brain, heart, lungs, kidneys. Okay? Blood is shunted away from non-vital areas. So everything else. One of those big areas is our skin. That's why we become pale, cool, and clammy. Because the blood is being shunted away from our skin. That's why we become pale, cool, clammy. What's the only type of shock where we're warm, red, and flushed? Neurogenic. Pulse pressure. What is pulse pressure? That's the difference in our systolic and diastolic numbers. So 120 over 80, what's our pulse pressure? 40. 120 minus 80, 40. So one sign that your shock is getting worse is when we have a narrowing of pulse pressure. We have a narrowing of pulse pressure. So let's say our blood pressure is 120 over 80. Our next one might be 115 over 85. What's our pulse pressure over 115 over 85? 30. Let's say our next one is 110 over 90. What's our pulse pressure? 20. We have a narrowing of pulse pressure. Okay, that's meaning our patient is now moving into decompensated or decompensatory shock.
They would have a high afterload, right?
Say what?
They would have a high afterload.
I can't hear you.
They would have a high afterload.
Afterload? Yes. So in decompensatory shock or decompensated shock, the mechanisms are overwhelmed. Okay, our body tried for as long as it could, but can no longer compensate. It's just not enough. So we can't maintain a blood pressure to perfuse our vital organs. So because our vital organs aren't getting the oxygen that it's needed, we move from an aerobic to anaerobic metabolism. What's anaerobic mean? Ana, without. Without oxygen. What is a byproduct of this? Lactic acid. A byproduct of anaerobic metabolism is lactic acid. All right, so we may also have what's called MODS. Okay, this is us just getting worse and worse and worse. So this is also referred to as irreversible shock, that third stage. We have compensated, decompensated, and irreversible. This is where multiple organs are starting to fail due to prolonged hypoxia. What's hypoxia? Lack of oxygen. Altered metabolism, elevated carbon dioxide, and acid levels. Why are the acid levels so high? Because they went into anaerobic metabolism. And what's a byproduct of this? Lactic acid. Okay? Our organs just can't function with that change of chemistry. Quick check on learning, or maybe a spot check bonus points. What is our pH level of our blood? Oh. Here's a better question. What is the pH of water? 7. Who said 7? Crushing it. Okay, blood is 7.4. That's our pH. Okay, and we have an acceptable range from 7.35 to 7.45. That's what we consider acceptable pH level in our blood. But as lactic acid builds up in our blood, what happens to our pH? It becomes more acidic. Becomes more acidic. And as we become more acidic, our body functions just do not work right. They just don't work. All right, so how do we assess all this? All right, so we're not going to rely on any one finding, sign, or symptom. It's the whole of the patient, okay? So pale, cool, clammy skin, maybe they're just like that, all right? But if they're pale, cool, clammy, and they're having difficulty breathing, or they're having increased respirations, narrowing pulse pressure, and then when we check in their history to find out what's going on, that OPQRST sample, we're going to use all of these tools to determine if they are in shock. Okay, beta blockers and calcium channel blockers can alter the response to shock. So this is for patients that have heart conditions, all right? So that's something to take into consideration. In compensated shock, vital signs could appear normal. Okay, they can appear normal, but they're not going to maintain that. They're not going to stay that way. They're eventually going to go into decompensated shock unless we do something for them. When it says look for signs of poor perfusion, what are some signs of poor perfusion? Say what? Pale, cool, clammy skin? What might we see around their lips? Maybe their fingernail beds. Bluing, which is called cyanosis. When we check capillary refill, what might we expect to find? It might be delayed more than 2 seconds. Those are all signs of poor perfusion. Here's some other signs. Okay, decreasing blood pressure, anxiety, anxiousness that progresses to a decreased ultimate mental status. Pale, cool, clammy skin, delayed capillary refill, like we talked about. Weak or absent peripheral pulses. Why would our peripheral pulses be absent? Oh, I can see it. It's in your head. Starts with an S. Shunting. Our body is starting to constrict all of those other blood vessels to our extremities because there's nothing vital there. Where's all the vital stuff? In our trunk, okay? In our trunk, and obviously our brain, all right? So it's like last-ditch effort. I don't care about my arms and legs. I care about my vital organs. Those are the most important things. That's what I have to take care of. Okay, we talked about this. Decreasing blood pressure. This is when we are starting to go down. We're starting to go downhill. Decreasing blood pressure. Narrowing pulse pressure. And we may see these in cardiogenic shock as well. Tachypnea or tachycardia initially. What is tachypnea? Tachy meaning fast. Pnea, breathing. Okay, tachypnea, fast breathing. What is bradypnea? Slow breathing. What if someone is apneic or they are suffering from apnea? Absent. It's absent. Got to know these medical terms. You're going to get them on your national registry and you're going to be like, what the hell is this? All right, we're talking about distributive shock. These are all signs and symptoms we might see in different types of shock, okay? You guys can go over these on your own. When we're talking about managing our patients that are in shock, if they're bleeding out, stop the bleeding. Number one, okay, HABCs. HABCs. Maintain the adequate airway, all right? If they're alert and oriented, or at least semi-conscious, we're not going to put an OPA in. Can you put an NPA in a semi-conscious patient? Yeah, 100%. They might not like it, but yeah, who cares? Don't do that. Oh, whatever. Okay, well, sorry, guy, you're dying. Okay, establish and maintain adequate ventilation. All right, so we're going to have to oxygenate these guys or possibly ventilate and breathe for them. But we're not going to hyperventilate them. Okay, we're not going to hyperventilate them. What's the rate that we're going to breathe for these guys? 1 every 6 seconds. Okay, good job. All right, some other things we can do. Splint fractures, but that's not our biggest concern. Transport is going to be our biggest concern. We don't remove impaled objects unless what? Unless it's in the chest and we can't perform CPR, or if it's in the affecting our airway. Okay, there's only 2 times that we remove an impaled object. Okay? And in the chest, obviously, it's a lot more dangerous to do so. But if we're doing CPR, that means that they're apneic and pulseless, so they're already technically dead. So do what you gotta do. Keep the body temperature. Keep them warm. Keep them warm. How are we gonna keep them warm? Blanket and turn the heater on. Okay? What do you think it's like in August here in Waco in the back of the truck? Brutal. It is brutal. Okay? But you have to do it. Okay. Did they talk about these at all? What a PASG is? Okay. You're probably never, ever going to see this or hear this ever again, but it's still used in some places, so that's why these books mention. This stands for pneumatic anti-shock garments. You're probably never, ever going to have to hear about this or worry about this. So what they are is that they are pants that you put over your patient and you inflate them. So I don't even, it's been so long since it's been relevant that I don't even really remember exactly what their point and purpose is. So what?
So you just lay on them, and does it push like into them?
It just compress. It's like, you know those do you guys see the arrow splints? Okay, that do that. It's kind of like the opposite of that, where we're inflating and just kind of squishing them that way. I assume that it's to kind of push that blood up into the main portion of the body. One reason why they're not used ever is because if someone has like abdominal trauma, what's going to happen if we start pushing all that blood to their abdomen? I'm just going to cause them to bleed out in their abdomen. Okay, so that's one major reason that pneumatic anti-shock garments aren't used anymore. So, and that's another thing. They don't even elaborate on what this stands for, but it's in your book, so I'm mentioning it. Okay, so shock is unusual in children because their blood vessels are usually pretty good. Okay, they're young, they're healthy. All right, cardiopulmonary arrest is typically due to respiratory failure. Almost always due to respiratory failure or shock. All right, newborns are known to go into shock from loss of body heat. So, what's one thing that we need to do immediately after a baby is born? We need to wrap them up. Okay, prevent hypothermia. Okay, newborns become hypothermic very easily. So you have to do what's called an APGAR score. Okay, have you guys covered that yet? Okay, well, I'm not going to cover it because you guys will get to it. But there's a score you need to do where you're checking their activity, their grimace, their pulse, respirations, all this stuff, and you'll learn all about it in a little bit. All right, so shock can be precipitated, or these are some reasons that can happen. Hypovolemic shock, obstructive shock, distributive, cardiogenic causes. Less common are allergic reactions like our anaphylaxis, poisoning, or other cardiac events. All right, signs of shock, and this is in pediatric patients. All right, and this is basically the same for adults as well. Respiratory rate, hypotension, pale, cool, clammy skin, mottling. Okay, mottling. What is mottling? That's where our skin. I wonder if I can pull it up here. Mottling. This mottling of the skin. All right, weak or absent peripheral pulses. Why does this happen? Because of shunting. Prolonged capillary refill. Why does that happen? Because of shunting. Same reason that we don't have those peripheral pulses is why we don't have good capillary refill. All right, again, controlling the bleeding, maintain their airway, ventilate if necessary, keep them supine, warm, and transport. All right, talking about resuscitation. Okay, so I'm gonna close this off here when we're talking about shock, because now we're gonna talk about resuscitation.